Vanakkam. Whether a phalangeal fracture has not been treated at all, or mismanaged, or even managed perfectly with a near perfect fixation of the fracture, complications can develop. That is because of the close anatomical proximity of the healing fractured bone with the extensor tendons and the flexor tendons, and the dynamic changes that are brought about by even small amounts of malalignment in the healing fracture. So it's only rational that we try to understand what are the complications that can occur after phalangeal fractures, why do they occur, and how can they be prevented, and if they do occur, how are they treated. We shall deal with all these in this video. We shall go straight to the complications of phalangeal fractures. Malunion, which could be extra-articular or intra-articular, non-union, stiffness and loss of movement, extensor lag, flexor rupture or adhesions, infections and contractures. We shall discuss all these one by one. Malunion is the commonest complication. It must be considered under the location, that is whether it is involving the proximal phalanx or middle phalanx, the digit that is involved, the level of malunion in the affected phalanx, and whether it is intra-articular or extra-articular. We also need to consider the complexity, that is whether it is an isolated malunion or whether it is combined with other injuries to the soft tissue or even joint stiffness. The third important consideration with respect to malunion of the phalanx is the nature of deformity. This could be of four types: malrotation, apex volar angulation, lateral angulation, and shortening. First, let us consider malrotation. This is usually seen after oblique or spiral fractures. It may not be appreciated with the digits held in extension as seen in this case, but it is best assessed by having the patient make a fist and looking for digital overlap, as we can see here where the ring finger overlaps the little finger. It is also a little difficult to assess radiographically, but we can make out small changes in the shape of the head of the involved proximal phalanx when compared to the neighboring uninvolved finger, the shape of the head of the middle phalanx or the orientation of the head of the middle phalanx, and the orientation of the tuft of the terminal phalanx, which is best seen in the lateral view. A small amount of malrotation is usually accepted by many patients, but when there is a greater degree of malrotation, it leads to functional impairment, pain from joint malalignment, and diminished grip strength. The treatment of this malrotation will be osteotomy. We shall discuss the details of how this osteotomy is done later on in this video. This case study shows a malrotation of the proximal phalanx of the right hand middle finger. The digital overlap of the mid finger over the index finger on flexion of the fingers is obvious. A rotation osteotomy of the base of the proximal phalanx of the middle finger was done and fixation done with plate and screws. The resultant movements and the correction of the digital overlap can be seen. The next type of malunion that can develop is the apex volar angulation. But why does it occur? Fracture of the proximal phalanx has a typical volar angulation. This is because of the pull of the intrinsics causing flexion of the metacarpal phalangeal joint and hence flexing the proximal segment, and the flexors acting on the proximal interphalangeal joint. If allowed to heal in this position, it results in a malunion with an apex volar angulation. This deformity is very clearly seen in this patient. Malunion of adult proximal phalangeal basal fractures with angulation more than 25 to 30 degrees causes pseudo-clawing, and the problems that they cause are: there is a compromise of dexterity, they are aesthetically unacceptable, and can result in fixed proximal interphalangeal joint flexion contractures. The management of such apex volar angulation is again osteotomy, which could be either opening or closing wedge osteotomy at the level of the malunion. For an apex volar angulation like this, an opening wedge osteotomy is made at the level of the malunion. It is opened up and a corticocancellous wedge-shaped graft is inserted to avoid shortening of the bone. Fixation is done with plate and screws. This deformity can also be corrected with a closing wedge osteotomy. Here, a wedge of bone with its apex facing dorsally and the base facing on the volar side is excised and the bone collapsed. Here, bone graft is not needed. Plate and screw fixation is then done. In this method, since bone is being excised, shortening of the bone results. In both the methods, fixation can also be done with K-wires, apart from plate and screws or even intraosseous wires. But early range of motion can be initiated at 5 to 7 days postoperatively only when plate and screws are used. The lateral angulation deformity can also occur in malunion. This occurs when there is a lateral translation displacement of the fracture. This angulation deformity can also be managed with an opening or closing wedge osteotomy as described earlier. This picture shows the opening osteotomy made, bone graft being applied and fixation with plate and screws being done. Malunion after phalangeal fracture can also result in shortening. This usually occurs after a comminuted fracture that is allowed to heal in a collapsed fashion, as shown in the picture where we can make out an obvious shortening of the middle finger. This shortening can also occur after a long spiral fracture. There is another problem that can occur in a long spiral fracture malunion. When the spiral fracture of the proximal phalanx heals in a shortened position, the distal spike on the proximal fragment protrudes into the retrocondylar space of the PIP joint, and this acts as a flexion block. This results in limitation of flexion at the proximal interphalangeal joint. There are 4 treatment options available for the treatment of this type of malunion. Restoration of the phalangeal length alone. This is rarely indicated because of the inherent risks of osteotomy and interposition bone grafting. Correction of the concomitant rotational or angular deformity if they are present can be done by a diaphyseal osteotomy with an appropriately fashioned intercalated graft, as we have already seen. In patients with the bony spike, digital flexion can be restored by removing the spike. If the shortening is due to a malunited subcondylar fracture through the neck of the proximal phalanx, removing the bony block to restore active and passive PIP flexion alone is enough. Osteotomy is not ideal because of the difficulty and the risk of avascular necrosis of the head fragment. As we have seen, phalangeal osteotomy plays an important role in the treatment of extra-articular phalangeal malunions. A particular study showed that full bony correction was achieved in 76% of the digits that were operated on, and 89% showed increased range of motion. With isolated malunion, 83% excellent results were seen, but when there were associated soft tissue injuries, only 45% excellent results were obtained. Apart from extra-articular malunion, we can also have intra-articular malunion due to unreduced condylar fractures which extend into the PIP joint. This results in pain, angulatory deformity, stiffness, and leads on to degenerative arthritis. There are 4 types of treatment options available. Corrective intra-articular osteotomy, which is done in young patients without post-traumatic arthritis. The patients should be informed that full mobility is unlikely and degenerative arthritis can develop in the future. Corrective juxta-articular osteotomy, which corrects the alignment but does not address the intra-articular step-off. Arthroplasty can be done in conditions of degenerative arthritis with the soft tissue envelope intact, and arthrodesis is indicated in conditions of degenerative arthritis with pain. Non-union is a complication which is usually uncommon in phalangeal fractures, but delayed union is seen often. Jupiter and colleagues advised operative intervention for fractures that had not healed within 4 months of injury. The treatment would consist of surgical removal of the fibrous tissue, freshening of the fracture ends, and if there is a resulting gap, intercalated corticocancellous bone grafting and plate fixation needs to be done. Textbook pictures show this procedure being done for a non-union with the resulting movements that were obtained. The next major complication that can occur is stiffness or loss of motion in the digit. This can be caused by tendon adhesions, either flexor or extensor, or capsular contracture, immobilization for more than 4 weeks, associated joint injuries, more than one fracture per finger, and crush injury of soft tissues are additional factors that bring about stiffness or loss of motion. This clinical example shows limitation of movements of the little finger following malunion of fracture of the proximal phalanx. Stiffness should be treated with an intensive hand therapy program consisting of active and passive motion exercises and dynamic splinting. Edema control with compressive garments is also important. Surgical intervention needs to be done only when there has been a plateau in motion and soft tissue induration and edema have been minimized. To understand the surgical methods of treatment of stiffness or loss of movement, we need to understand the exact cause why this has occurred. This problem can occur due to joint ankylosis, capsular contracture, extensor adhesions, or flexor adhesions. To differentiate these conditions, we shall analyze the PIP joint flexion, PIP joint extension, and subsequently the treatment options available for each of these conditions. In joint ankylosis, there is no range of motion in the PIP joint flexion or PIP joint extension, and the treatment options would be arthroplasty or more ideally arthrodesis. In capsular contracture, there will be a free active motion beyond a certain point in PIP flexion, and extension will not be possible of the PIP joint beyond that particular point. In such a situation, contracture release, that is, volar plate release and collateral ligament release needs to be done. In case of extensor adhesions, passive and active flexion will be restricted, but full passive extension of the proximal interphalangeal joint will be possible. Extensor tenolysis is indicated in this condition. If there are flexor adhesions, the passive flexion range would be full, but there would be a restriction of the active flexion range, and in PIP extension there would be full passive extension, but active extension can be restricted. A flexor tenolysis is indicated here. A combination of these problems may also present, and different surgical options need to be exercised. In this clinical example, with fracture of the shaft of the proximal phalanx of the ring finger, K-wire fixation had been done and good healing of the fracture has been noted. But on movements, we can make out a deficit in full flexion of the ring finger due to flexor adhesions. Proximal interphalangeal joint extensor lag is also a common problem that can be seen following phalangeal fractures, and this problem is much more common with the volar angulation deformity of the phalanx. This extensor lag could be caused by adhesions of the dorsal apparatus to the proximal phalanx or shortening of the proximal phalanx. In this clinical example, we can make out the volar angulation deformity on the proximal phalanx of the index finger and the resulting extensor lag at the PIP joint. A study has shown that volar angulation of 16, 37 and 46 degrees produces a PIP joint extension lag of 10, 24 and 66 degrees respectively, and a shortening of 1 millimeter of the bone produces a 12-degree extensor lag. Ideally, prevention of this extensor lag is the management of choice. The PIP joint should be statically splinted in extension. If an extensor lag is noted, a dynamic PIP extension splint with a lumbrical bar to prevent metacarpophalangeal joint extension should be used. Usually, a lag up to 15 to 20 degrees is tolerated. But if the lag is more, the underlying problem should be corrected first, and if symptomatic and adhesions are suspected, extensor tenolysis should be considered. Flexor tendon rupture is uncommon. It is usually iatrogenic secondary to attritional rupture from screws that penetrate the fibroosseous sheath. But adhesions of the flexor tendons to the fracture site is quite common. Flexor tenolysis is indicated when the passive range is full but active range of flexion is present but less than normal. The incidence of infection as a complication of phalangeal fractures ranges from 2% to 11% as evidenced from various studies. It usually occurs after an open injury in which there has been a soft tissue injury, a comminuted fracture or contamination. A study conducted in 1991 by Swanson and associates who reviewed 200 open hand fractures in 121 patients classified fractures into two types. Type 1 injuries consisting of clean wounds without significant contamination, no delay in treatment and no significant systemic illness, whereas type 2 consisted of wounds with gross contamination like animal bite, grossly dirty or farm injury, delay in treatment greater than 24 hours with significant systemic illness. When infected fractures are being treated, the aims are eradicating sepsis with thorough debridement of the infected bone and soft tissues and initiation of appropriate antibiotic therapy, obtaining fracture union which could be with external fixation, and regaining a functional extremity which may need several operative procedures. But if the final result is a painful, stiff, useless digit, amputation may be considered. Contractures are a complication that occur when compound fractures of the proximal phalanx are treated conservatively. They can occur in simple fractures also, and they are mostly iatrogenic, as in this example, in whom a fracture of the base of the proximal phalanx of little finger was managed with a POP slab, but later swelling and blisters noted on the little finger, which broke down, yielding an ulcer, which was then resurfaced with a flap cover. So the important criteria to be considered when managing compound fractures of the proximal phalanx are adequacy of skin cover, skeletal stabilization, and soft tissue management. Let us now summarize the complications that can occur following phalangeal fractures. The first is malunion, which could be with volar angulation, lateral angulation, malrotation or shortening, nonunion, stiffness or loss of movements, extensor adhesions or lag, flexor adhesions or rupture, and skin contractures. And in the management of these complications, especially malunion, we have noted that osteotomy is one of the commonest procedures done. So we shall try to understand osteotomy by learning about the basics of osteotomy, the rules of osteotomy as laid down by Paley, osteotomy with reference to phalangeal malunions, and post-osteotomy care. Osteotomy is basically a surgical procedure where a bone is cut to shorten or lengthen it or to change its alignment. And it is this property of the ability of osteotomy to change its alignment that we apply in phalangeal malunions. Whenever there is an angulation in bone, we need to mark the anatomical axis of the distal and proximal segments and note the intersection point, which is known as the center of rotation of angulation, CORA or CORA. The bisector line through this CORA is the Angulation Correction Axis ACA. Sometimes the Cora and the ACA may not coincide in case of multiple deformities. To make the understanding easier of where to make the osteotomy, Paley laid down the rules of osteotomy in 2002. The first rule states that if the ACA passes through the Cora and the osteotomy also passes through the same line, correction produces pure angulation at the osteotomy site. There is no translation of the bone. In this representation, the ACA, Cora and osteotomy are all at the same plane. In such a situation, whether we do an opening wedge osteotomy and incorporate a wedge-shaped bone graft or a closing wedge osteotomy where we remove a wedge-shaped bone, it is only the angulation that is corrected and there is no translation of the bones. The second rule states that if the ACA passes through the Cora but the osteotomy does not pass through either the ACA or the Cora, there will be angulation and translation of the bone ends at the osteotomy site. But the axis lines are collinear. There is no translation of the axis. Let us try to understand this better with diagrams. We can make out that the ACA and Cora are in the same line, but the osteotomy represented by the green line is at a different place. So osteotomy at this place, whether an opening wedge osteotomy or a closing wedge osteotomy, angulation and translation of the bone ends is produced, but the axis of the proximal and distal segments represented by the white and blue dotted lines coincide. So, no translation of the axis of the bones occurs. Rule 3 states that if the osteotomy passes through the ACA, but the Cora is at a different level, there will be angulation but no translation of the bone ends. The axis lines will be parallel, but the axis will be translated as such. In this representation, the osteotomy is at the line of the ACA, but the Cora is at a different level. In such a situation, whether an opening wedge osteotomy is done or a closed wedge osteotomy is done, there is angulation, but the bone ends have not been translated and the axes of the proximal and distal segments are parallel. So depending on whether we want correction of the angulation only or translation only or correction of both angulation and translation, we need to decide on the osteotomy site after assessing the Cora and the ACA. To make it more simplified and easier to understand, let us see how the osteotomy is done for phalangeal malunions. The first question is whether we need to do an osteotomy at the proximal phalanx level or the metacarpal level, and the next question is whether we need to do an opening or closing wedge osteotomy. When the osteotomy is done at the proximal phalanx level, it corrects the malunion at its site of origin, allowing for multiplanar correction. It also allows concomitant soft tissue procedures such as stenolysis and capsulotomy. But the potential disadvantage is that postoperative adhesions may develop between the dorsal apparatus and the phalanx, leading to digital stiffness. Before the development of secure internal fixation, malrotation was corrected by an osteotomy through the metacarpal base, and metacarpal osteotomy was described by Flexor. The advantage of doing an osteotomy at the metacarpal level for a phalangeal malunion has the advantage in that it is technically easier, but the disadvantages are that the amount of rotational correction is limited, multiplanar correction is impossible, and it is not possible for concomitant tenolysis or capsulotomy, which may be required. Corrective osteotomies at the proximal phalangeal level are ideal. They can be opening wedge osteotomy, closing wedge osteotomy, or rotation osteotomy, which are the most commonly used. Let us see how the opening wedge osteotomy is done. For an angulation in a bone like this, the distal axis is marked, the proximal axis is marked, and the angle between the two, here 40 degrees, is noted. Now the Cora and ACA are marked. In an opening wedge osteotomy, the apex will always be on the convex side and the base of the wedge is on the concave side. Now the osteotomy has been made and the bone straightened. A wedge-shaped gap in the bone now results, which must be filled up with an intercalary bone graft, which has an apical angulation of 40 degrees. Because we have used a bone graft while straightening the bone, it will result in lengthening or maintenance of the length of the phalanx. In a closing wedge osteotomy, again, the distal axis, the proximal axis are marked and the angulation is noted. In a closing wedge osteotomy, a wedge of bone must be removed, which has its apex on the concave side and base on the convex side. After removal of this wedge of bone, the angulation is corrected, but it will result in shortening. Rotation osteotomy is a procedure indicated for malrotation. Here we can note a rotation of the distal segment with respect to the proximal segment as evidenced by the marking of the blue and white dotted lines. This rotation has been through a distance marked by the red dotted line. A transverse osteotomy is done at this level and the distal segment is derotated to align with the proximal segment. We can also check the alignment of the nail plate to confirm the derotation. A plate and screw fixation holds this in position. The postoperative care after osteotomy consists of application of bulky dressing for about 4 to 7 days and beginning intensive, active and gentle passive range of motion exercises, edema control and splinting the interphalangeal joints in extension when not exercising. I hope you enjoyed this video. Please do click on the shown links to see more about phalangeal fractures, the head fractures, the neck fractures, the shaft fractures and so on. And do not forget to subscribe to stay connected with the latest in learning hand surgery, trauma surgery and plastic surgery.